so that we are going with that.
Sure, I can go
Roy?
from here, Veronica, if that sounds okay.
Yeah.
Excellent.
Great. We'll go ahead and get started, everyone. Welcome. Welcome to all of you for coming. This is really a wonderful series. It's the two-part presentation by Dr. Bruce Trigg. I'll give a real brief introduction, a little bit shorter than what I did last week, but I just want to thank the Center for Teaching Excellence, Veronica Black, the Department of Counseling and the School of Education, Dr. Lori Rudolph, for collaborating on this project. It's been really a joy, to come together and see the fruits of the collaboration with Dr. Trigg's presentation. Dr. Bruce Trigg currently lives in New York City. He consults on addiction treatment for the New York City Department of Health and Mental Hygiene. He is a pediatrician, public health physician, and addiction medicine consultant, and worked for the New Mexico Department of Health for 25 years, where he helped to implement one of the first statewide harm reduction programs in the US. So he knows a lot about New Mexico. I think with that, Dr. Trigg, I'll go ahead and turn it over to you. Again, thanks to everyone for coming and for the collaboration. And we look forward to this evening's presentation. Thank you.
Thank you so much, Dean Duran, and thank you to all the sponsoring deans and departments. Let's screen share, and I will do a very short recap, okay? That we have 3 Food and Drug Administration approved evidence-based medical treatments for opioid use disorder. And they are in 3 categories. The first ones are full agonists like methadone, and so are the drugs that can be misused are also full agonists. So they occupy the sites in the brain, and when they are, and depending on the amount that's taken, it can end in respiratory depression and death. Buprenorphine is a partial agonist. So while the receptors are occupied, they're not fully activated. And buprenorphine has this incredible ceiling effect, as we call it, meaning that beyond a certain dose, taking more in adults has no effect whatsoever. And therefore, it's virtually impossible to overdose on buprenorphine by itself. And third, we have the antagonist group, which is naltrexone, and also naloxone, or Narcan, which is used to reverse overdoses. And those 2 medications are antagonists. They occupy the receptor and they don't allow the opioids to occupy it, and they'll throw off the opioids if they're already on there. So the main point I want to take before I start on buprenorphine is that buprenorphine, even though it only partially activates the receptors, it also grasps onto them with great intensity. I tell my patients it's like a vase, it grasps onto it. Okay, so let's say you have methadone or heroin in your brain receptors, and you take buprenorphine. The buprenorphine will grasp those receptors and throw off the methadone or heroin. By throwing them off, people go from being this high up here to down here, and they go into withdrawal. So that's the pharmacokinetics, okay? That even though it has a weaker effect on the receptors, it grasps them much more strongly and therefore displaces the full agonists, and that's why people go into withdrawal if they are taking buprenorphine if they're taking methadone or heroin and they take buprenorphine on top of it. So that's the key issue in this medication. So now I am going to end the slideshow and go on to what happened? Yeah. So we talked a lot about methadone, which is the most studied medication in actually all of Western medicine for anything, because it's been around for more than 50 years and it's used in about 95 countries in the world. And it is still the gold standard for treatment of opioid use disorder. And a new medication called buprenorphine was synthesized in 1966, and it was approved by the US government in 2002 as the first medication approved for treatment of opioid use disorder that could be prescribed not in a specialized methadone center or opioid treatment program, but by any licensed primary care provider who had the special licensure to prescribe it. So this was a very important step forward, because methadone, even though it's a very effective medicine, its effectiveness really is hindered by the complicated regulations that essentially require people to go to a clinic every day for a very long time. In distinction to buprenorphine, which most doctors or nurse practitioners or PAs will start people with a week of take home. And then very rapidly, once they're stabilized, they go to 2 weeks, 4 weeks, and even to 2 months. In fact, in the era of COVID, there are people I met who are going every 3 months. So their prescriptions are filled, and they only need to see the provider in person or on a video every 3 months. This is very different than methadone. So at the beginning, in 2000, when the law was passed to allow prescribing of buprenorphine, it was only for physicians, only licensed physicians who went through an 8-hour training and took a test and then were licensed by the DEA, the Drug Enforcement Administration, the men with guns, who oversee, basically are involved in keeping heroin and other dangerous drugs out of the United States. So they regulate it, and so does SAMHSA, the Substance Abuse Mental Health Services Administration. So like methadone, there are 2 big federal agencies that oversee it. One, a police agency, essentially, an enforcement agency, and the other, a public health agency. So at the beginning, only doctors could prescribe it. So what did we say in New Mexico? This is going to be a problem because a lot of primary care in rural New Mexico is not provided by doctors. It's provided by nurse practitioners and physician assistants. That's who I worked with in the Indian Health Service and in the Department of Health. So unfortunately, it took 13 years to get that changed. But finally, in 2016, the federal government passed, and this is federal legislation, passed a law. I think it was unanimous, actually, if you can imagine the US Congress actually passing something unanimously in this day and age. They passed a law that nurse practitioners and PAs could also now be licensed. They are required to get 24 hours of training. Usually it's 4 hours in person, and the other 20 hours are done online. But they then can be certified. And just like the doctors, they are limited to having 30 patients at one time the first year. So you might start 100 people on buprenorphine, but at any given moment, you can only have 30 active prescriptions. So this requires that you keep track of all your active prescriptions. Now, we used to do it with a pencil and paper, or, if you're computer savvy, you could work out a very simple, computer program. But actually, the physician monitoring program, the prescription drug monitoring program, or the PMP, as they call it, I think, in New Mexico, from the Board of Pharmacy, it makes it very simple to just plug your name in, and it shows all the prescriptions you've given, and you can see quickly which ones are active. So you are required to keep track and have no more than 30 patients. Now, how much of a problem is that? It only occasionally, because most people the first year are not prescribed, don't have 30 patients. Many of them don't even have 1 or 2. Many have 0 patients the first year. No matter how many patients you have the first year, whether you have none or you have 29 or 30. After 1 year, you can apply to have 100 patients at one time. And now there are special settings where you can have 275 patients. So it's a hassle. I wouldn't say it is the defining hassle. Now, the rules for prescribing buprenorphine were that you had to start in person. In other words, you had to have a face-to-face meeting with the clinician to start the medication, but afterwards you could continue it on a video as long as the video was approved by the federal government, by the DEA, I think it was, as being HIPAA compliant. You know, that it was impossible to basically, you know, you didn't want to risk having that people, you know, have access to that. But under COVID, the rules changed. And now you can actually start someone on buprenorphine, not only on a video, but on a telephone call. You don't have to see them in person. It can be simply a phone call, and you can do all the follow-ups that way. If patients, you know, it's obviously preferred if they have a, you know, Skype access or Zoom or, you know, or FaceTime, but it's not absolutely necessary. So there are patients who come right out of jail. They don't have a phone. They're in a homeless shelter, and there's a payphone, and on the phone, they can get their prescription started or continued. So this is a big innovation that we hope will continue after the COVID crisis. So what does buprenorphine do? It does exactly what methadone does. It takes away the sickness of withdrawal, it diminishes the craving, and it blocks the ability to get high if you take illicit opioids. So if you're taking the right dose, which we call a blocking dose of, usually it's 12 to 16 milligrams of buprenorphine, then if you get high, if you see your buddy that night and they say, let's get high, and you can't say no, you can shoot the heroin, but you won't feel it. You can't feel it. It actually blocks the ability to get high. So this is a very powerful combination of effects, but you have to be on the right dose. So the idea that, well, this is, you know, a narcotic and it's, you know, opioid, and we're just going to give you as little as possible is not good medicine, because a tiny dose will block withdrawal, and a middling dose might decrease the craving. But if you really want to protect your patient from relapse, and that's really the goal, right, then the patient has to be on the right dose. And the right dose is 12 to 16 milligrams. And actually the maximum dose of buprenorphine is 24 milligrams. So it's a very narrow, you know, therapeutic range. But again, you want to give patients the right dose, not just, you know, the smallest dose. It's taken under the tongue. And now there are some injectable forms that, of course, are injected, but it's generally taken under the tongue or against the cheek. That's called buccal. But if you just swallow it, it only 5% is absorbed. But if you take it under the tongue as prescribed, it takes 5 to 10 minutes to dissolve. It works very nicely, and it's usually taken once a day, but actually it can be taken every other day. You double the dose, and there's settings and there are programs around the world that I know of where people come 3 times a week to pick up their buprenorphine. Those are countries that don't allow generally take-homes. But in the United States, we usually prefer to just do it you take it every day. It's a 24-hour medication. It's not detected on typical, you know, like people say, well, I'm applying for a job at, you know, at McDonald's, and, you know, they're going to drug test me. It would be very unusual for them to test you for buprenorphine. It would be extremely unusual because it's a very specific lab test. They test for, you know, other opioids like heroin, of course, but not for buprenorphine. And when I say to the patients, you know, it's not really your boss's business what medications you take. It is really not their business. So you have no need to divulge this information. And if it ever showed up on a drug test, I would say, no problem. I will have a letter in your hand or a phone call from my doctor in 1 day. That's it. That's the end of the story. And then I tell them that if they fire you because you're on buprenorphine, you have a lawsuit. And I tell them that I will put on a suit and testify on your behalf for free. And you'll get a chunk of money because, again, you're not allowed to discriminate against people who have a medical chronic condition, period. So, the whole idea is we want to destigmatize this. We don't want people to feel bad, like they have to hide this, like they're somehow, less worthy than other people because they're on treatment. No, they are on the absolute best treatment for their opioid use disorder. It has a minimal sedating effect because of that ceiling effect I mentioned. And I've had many patients who had been on methadone in the past, and they said, I like buprenorphine better. I don't feel as sedated. I feel more clear-headed. So if your patients want to feel clear-headed, which hopefully they do, this is a great medicine for them. It is always mixed with naloxone. Whenever it's given in the sublingual form, it's always mixed with naloxone. So the medicine is not, I say buprenorphine, but whenever I say buprenorphine, what you should be hearing is buprenorphine plus naloxone. Now, why is that? Naloxone is an opioid antagonist. So why would you mix it with the buprenorphine? And there's only one reason it's mixed with buprenorphine: to discourage injection or inhaling. In other words, to limit and to discourage misuse of the medicine. Because if you decide you want to inject it, and if you've been using opioids, then the naloxone will put you into withdrawal. And people who use drugs really don't like to go through withdrawal. So the very fact that it's mixed with it and everyone knows it discourages misuse of buprenorphine, okay? So it's always mixed with naloxone, with one exception. That's pregnant women. Up until relatively recently, it was felt to be safer in pregnancy and breastfeeding to use pure buprenorphine. However, data has been accumulating because, for one thing, a lot of women have become pregnant while they were on the combined product, and there have been no birth defects or no fetal anomalies or no problems that have been found. So increasingly, OBGYNs are saying you don't really need to be on the pure buprenorphine. You can be on the combined product, which is much more common. Now, Suboxone is what all our patients call this medicine because it's a mouthful to say buprenorphine plus naloxone, right? Even I don't say that. So therefore, everyone calls it Suboxone. So what is Suboxone? Suboxone is a film. It's only the film now. There used to be a pill, but now it's just a film, and it's the combined buprenorphine and naloxone. It's always in a 4-to-1 ratio. So if it's 8 milligrams of buprenorphine, it's 8/2, 8 milligrams of buprenorphine and 2 milligrams of naloxone. And whatever the dose is, it's always in that ratio. So Suboxone is just the name of a brand of a it's a brand name. Again, it's like calling soda pop Coca-Cola, right? A lot of people go, I'll have a Coke. Well, it's really, it's really a, I don't even know the names of soda pops. It's, okay, but it's just a brand name. So now we have films which dissolve pretty rapidly, and we have tablets which take a little bit longer to dissolve, and we have the buccal film that goes against the cheek, and then we have different generics, like one is called Zubsolv that has a different doses. So the chart you get when you prescribe Zubsolv gives you the equivalent essentially to Suboxone, to the 4-to-1, but it's just different doses. And the really big innovation that's quite recent in the last 2 years is Sublocade, which is a 1-month injectable. So what if I have a patient who, for some reason, can't take the medicine every day? He or she may be unhoused and they don't have a secure place to keep it, or they're living with people who are struggling with addiction and are taking or threatening them or begging them for their Suboxone, and they just can't keep enough of it around for themselves. This would be a perfect patient to say, I have an alternative for you. Why don't we give you an injection once a month? And in fact, the injection gives you a very high blood level equivalent to 24 milligrams of buprenorphine sublingual. So it gives you basically the maximum dose, and people do extremely well on it. And sometimes they don't come back in a month because it actually lasts more than a month. But they're not missing appointments because they're relapsing, but really because the medicine is still active and protecting them. So this has really been a dramatic change in the treatment of opioid use disorder, having this 1 month treatment. There's also an implant, and I won't even mention it. It's a sort of a bloody mess. If you remember the birth control implants that we used to do. Well, we still have them, but we used to have one that had, I think it was 5 rods, right, in the old days, and now it's just 2, I believe, or 1. But the Buprenorphine lasts only 6 months, so you have to take them out and put them in, and it's really not that good a treatment. So here you see on the right what the Suboxone film looks like. And you could, of course, cut it in half if you want, or you can cut it in quarters if you need to, depending on the dose of your medicine. And then on the left is is a tablet that goes under the tongue. And then the other 2 are forms of pure buprenorphine that are only used for pain management, that are not approved for use in addiction, not approved for opioid use disorder. These are pain medicines. So buprenorphine, like methadone, is a very effective pain treatment. It's because you only need to take it a couple or 3 times a day. I mentioned that Suboxone is taken usually once a day because it lasts 24 hours. However, for treatment of pain, just like methadone, you have to take it more than once a day. You generally have to take it every 8 to 12 hours. So if I have a patient who is stable on, say, 16 milligrams of Suboxone, and they're going to have surgery, what I would recommend is that we'll divide their dose up into 3 parts. And if they need additional pain medicine on top of the Suboxone, all they do is give them short-acting opioids. Now, some oxycodone or even fentanyl if they need it. But usually now we prefer not to stop the Suboxone. We used to stop it, and then people struggled to get back on it and often relapse before they got on it. And now we know that's necessary. So we've learned a lot about this medicine. The only slight complication is that when you start the medicine, the patient has to be in mild to moderate withdrawal, because as I explained the way the medicine works, if they took heroin 4 hours ago and they take the first dose of buprenorphine, they'll go into withdrawal and they'll be very sick. That's called precipitated withdrawal. So to avoid that, we recommend people wait at least 12 hours from their last dose of either a prescribed medicine like oxycodone or a street medicine like heroin or whatever opioid they're using. So this requires counseling and some hand-holding for some patients, but the reality is that almost every patient I've had has bought or been given buprenorphine on the street or by someone they know or by a friend, and they have figured out that to avoid the withdrawal, they have to wait a certain number of hours. Now, some patients didn't receive that information and will say, oh, I got really sick, I must be allergic to the naloxone. But it's actually not the naloxone that made them sick. It was the buprenorphine that made them sick. I'm not sure how clear I was. Naloxone is not absorbed if you take it under the tongue the way you're supposed to. It plays no role whatsoever. The naloxone is only active if you inject it. So therefore, the patients didn't get sick because of the naloxone. They got sick because you're not supposed to take buprenorphine when you have a full agonist opioid in your system. So any clinic or program that does this, any provider will have an information sheet, because increasingly we're doing home inductions. You don't have to, you can be in the office, and most clinicians will do a few office inductions. But now, especially with COVID, even more than before, are doing home inductions. Basically, you give the patient the information they need. You give them a phone number to call if they have a problem, and you give them instructions about how to start the medicine. So I'll tell you very rapidly that the patient waits 12 hours and they have to have mild withdrawal. And we measure that with what's called a COW scale, clinical opioid withdrawal scale, that gives a mostly subjective scale for withdrawal. And once they have a scale, a score of 8 or above, they take usually 2 to 4 milligrams under the tongue and wait 30, 40, 60 minutes. If they start getting sick, you've precipitated withdrawal and they need more buprenorphine immediately. But if they have been in adequate amount of withdrawal, then they start feeling better. And after 30, 40, 50 minutes, you give them another 4 milligrams or another 2 milligrams. And then you watch them in the office until they've had at least 8 milligrams and they feel well and they can be driven home. We don't like patients, driving themselves if they're starting on a new medicine. But it's really very simple. Once you've done it a few times, and once you've done it hundreds of times, it becomes really a piece of cake. So buprenorphine, it is a opioid, and it has some sedating effects. And if it's mixed with benzodiazepines or alcohol, it can be too sedating. And there have been very few deaths, almost none, from just buprenorphine, almost zero. And the few that have happened also involve benzodiazepines and alcohol or alcohol. So patients should be warned about this. However, in the old days, if someone was using benzodiazepines, we said, you can't be on buprenorphine. That is no longer the current recommendation. Even if someone is on benzodiazepines that are prescribed or that they're misusing or that they're overdoing, it's still safer for them to be on buprenorphine than it is for them to be out in the street injecting heroin that may be laced with fentanyl. On the other hand, what you do is you don't ignore the fact that they're in benzos. You call up their provider who prescribes them. So I used to call up and say, this is my patient and I'm treating them for opioid use disorder and you're prescribing benzos. And there'd be a long pause on the other end of the phone and the doctor or nurse would say, I'm going to stop them immediately. And I would say, please don't do that. If you stop benzodiazepines, immediately people have seizures and they can die. So what you do is you work out an agreement that the clinician will work with the patient to slowly taper them off benzos. And that's a very complicated, that's a real art of medicine thing to do, because people are very attached to the benzodiazepines because they need them for their anxiety. However, it's not safe for them to be on them with buprenorphine ultimately, but it's not a reason to stop or to refuse to start people on buprenorphine. So that's become very clear. I already mentioned that it's used in pregnancy, and probably it will become the treatment of choice for women who are using opioids who are pregnant. In the past, the medicine of choice was methadone. However, the problem is some women don't want to be on methadone. They don't want to have to go to a clinic every day, or they may live in a great distance from a methadone program. And it's not a good idea, really. It's not safe to be driving 2 hours each way to a methadone clinic every day. Another issue is that a newborn, if the mom has been using methadone, is very likely to have neonatal abstinence syndrome or neonatal withdrawal syndrome, as we prefer to call it now. And this means that the newborn has withdrawal, and this is mistakenly called an addicted newborn. Newborns cannot be addicted. That is a bad term to use, because addiction is compulsive use of a drug that's out of control despite negative consequences. So the newborn isn't doing anything out of control. The newborn is simply withdrawn because it's no longer, it's no longer has the medication that was in the placenta, right? So it's really a very stigmatizing term. And women who have babies who have been on buprenorphine or methadone, and the newborn has withdrawal syndrome, are super guilty about it. And often it's not just family members, but even people in the medical profession who are like, oh, look what you did to your baby. And that's really a very unfortunate attitude, because these women are actually doing the best thing possible for their baby. What is the treatment for neonatal withdrawal syndrome? The mother's arms and breastfeeding is the most effective treatment. Very few newborns in that situation really need to be in an ICU. Now, often they are shipped to an ICU. They're transported from a small hospital to a big tertiary care center, and the mother can't sleep in the ICU, and it's really a mess, and it's completely unnecessary. Every hospital should have a nurse or 2 or 3 who are trained in taking care of newborns with neonatal abstinence syndrome. They don't need to be in an ICU. They should be in a room and in the mother's arms. That is the treatment. Mother is the medicine. They
Dr.
will.
Trigg, we're at 30 minutes.
30. Okay, thank you.
Yes.
They will occasionally, by the way, require very small doses of morphine or or an opioid or even methadone, depending what the hospital uses. But it's really very rarely a dangerous situation. And the reason that we want women to stay on treatment is because if they relapse, if they're discouraged to continue treatment after the baby is born, they will have a very high risk of relapse. And the worst possible thing for a newborn or any child is to have a mother and or father who has no control over their drug use. It leads to very unfortunate outcomes. And a woman or man with opioid use disorder, by definition, has no control over their drug use. And these children have very difficult lives. But their difficult life is not caused by the mother being on methadone or buprenorphine. Adolescence. I've had many patients who started using opioids or even heroin when they were 11, 12, 13, 14, 15, 16. They were all in the pediatric age group, and very few of them were ever started on appropriate treatment. Methadone can't be started before age 18 without special paperwork and rigmarole. Buprenorphine is approved down to age 16. If there was a young person who was putting a needle in their arm, would I offer them buprenorphine? I would. I would offer them buprenorphine immediately. Do they have to try a detox program and an abstinence program? No. This is a very deadly disease. If the family wants to try detox, I'd say go for it. But I would definitely tell them that if it doesn't work, it's really vital that they get on buprenorphine and not be like that young woman who I discussed last week, who'd been 8 times in detox in her life and started using heroin at age 15, and now she's at high risk of dying at age 23. We can avoid that. Start them early, and that really needs to be done. And there are programs in New Mexico now that start this. So buprenorphine works. This was one of the first studies. They had 40 people using heroin. Half got buprenorphine and half got placebo. Within 1 year, 0 of the people on placebo were still in treatment. They were still offered counseling. They were still invited to come to the program, and none of them were still coming. But 70% of the buprenorphine folks were still coming after a year. And 4 of the placebo patients died. That was 20% of them. So we never need to repeat this study. It was done once. We don't have to do this. We know people stay in treatment and they're much less likely to die, and they're much less likely to be drug dealing and doing prescription fraud and other crimes like methadone. buprenorphine is an anti-crime pill. So if you had anything to do with the criminal justice system, or if you live in the community and don't want to have bars on your windows, we all have an interest in getting everyone who wants and is interested on buprenorphine or methadone. This is the way you deal with crime in our communities. It's largely caused by drug use. In fact, I may have mentioned it last week, the police chief of Santa Fe, I'll never forget, he said 100% of the burglaries in Santa Fe are people who are addicted to heroin. He knows because they arrested them and they all were addicted to heroin. So how do you stop burglaries in Santa Fe? You offer buprenorphine to everyone who gets arrested. And there's a program that's trying to do that called the LEAD program. If you are in the general population, this is your death rate from all causes of death. If you have opioid use disorder and you're not on treatment, your risk of death is 6 times what it is for everybody else in the community. If you're on medication-assisted treatment, methadone or buprenorphine, your risk of death is less than twice the general population. That's pretty darn good. We also have population level data. This is the city of Baltimore, which like New Mexico and New York City, has had a long-standing heroin addiction problem for many, many years. But in Baltimore, in 2002, when they approved buprenorphine, they immediately started getting as many doctors to prescribe it as they could. Again, it was only doctors back then. And what they were able to show is this is the number of patients who were treated with buprenorphine. It went up to 8,000. And this is the death rate, the red. Look at the death rate. It plummeted. So you don't have to look to other countries. We know what happened. They did it in Baltimore. They got 8,000 people on buprenorphine and they plummeted the death rate. So why on earth haven't we done this all over the United States? Why? For a lot of reasons. That's why I'm glad you're here for this talk. Well, first of all treatment with medication-assisted treatment or medication for addiction treatment is under the shadow of this misconception. Aren't you just replacing one addiction for another? And when I have a live audience, I used to say, how many of you think methadone and buprenorphine is replacing one addiction for another? And if people weren't, intimidated by me, half the hands shot up in the audience. These were health professionals or counselors or nurses, or doctors. This is very widely believed everywhere. And certainly the police believe this, and the sheriffs believe this, and the judges believe this. So I'm going to deputize everyone on this call tonight to never let this statement be made in front of you without politely correcting people. And just point out that addiction is out of control, compulsive drug use, and use of drugs despite negative consequences. And being on methadone and buprenorphine do not meet those criteria. It is not out of control. As a matter of fact, these are the 2 most controlled medicines in all of medicine in the United States. These are super controlled. They're too controlled, in my opinion, right? And there's nothing compulsive about it. You go to a medical setting and you're given a prescription and you go to a pharmacy and you take the medicine once a day. That's not out of control. So don't let people continue this stigmatizing attitude. This saves lives and it improves people's lives and it improves the families' lives and it makes the whole community safer. So why wouldn't we be encouraging this rather than misrepresenting it and spreading this falsehood? And I think I referred to this last week, that when you use heroin, that's the red, this is opioid-induced euphoria. This is getting high. In 10 seconds, your brain is exploding with pleasure, right? You are high as a kite. If you take methadone or buprenorphine, you don't feel anything for 30 minutes, and the peak is 3 hours. And the peak, even though the peak of methadone can get this high, it's very slow onset. And for buprenorphine, the peak is only like half of what you get from methadone. You're not even that high. So this will never replace heroin for people whose sole purpose is to get high. These medicines only really are effective for, some people will obviously experiment with it. If they can't get heroin, they'll use it to get a buzz. But in reality, it's been around now for, almost 20 years. We have not seen an epidemic of buprenorphine addiction in the United States. It just doesn't do it. And the nice thing about buprenorphine is it's prescribed by primary care. It can be prescribed by a psychiatrist. It can be prescribed at an opioid treatment program, but ideally it's prescribed by the same nurse practitioner or physician's assistant or primary care doctor who takes care of your hypertension and your diabetes and immunizes your kids, right? It's just another medical treatment. So it really, but we've learned a lot about its use. And one thing is we need to start low threshold. We don't want people to have to jump through a lot of hoops to get started. A very nice federally qualified health center that I won't name in Albuquerque required 2 meetings with a counselor separated by a week before you got to have an appointment with the doctor. And then the doctor, the first meeting, had a discussion with you, but couldn't start the treatment until the next appointment. Well, what's wrong with that? That sounds very nice. Let's get to know the patient. Let's talk to them about all their problems. But there's a problem. You're sending people out for 3 or 4 weeks to keep shooting heroin, and the heroin may have fentanyl, and it may be the end of their life. And many patients are not going to wait. They're not going to come back 4 times. So the doctors and nurses that I spoke to there said, oh, our patients are doing fine. Well, why is that? They were cherry picking the patients who had the most stable lives, had transportation, could keep an appointment, right? Were able to keep coming back, but they were completely excluding patients who were on the street, whose addiction was completely out of control and couldn't keep 3 appointments, 4 appointments to start on the buprenorphine. So that is a huge mistake. We want to start people ideally the day they call up. We have an hour at 4 o'clock. Come in, we'll start you today. Or tomorrow morning, come in at 8 o'clock in the morning, we'll start you. Don't make people jump through hoops to get a life-saving medicine. We wouldn't do this for any other disorder or disease in medicine. Oh, take your time, Abstinence is not should not be imposed as a precondition. Patients don't have to swear that they want to completely stop using drugs. For one thing, they may not want to completely stop using drugs, so why make them lie to you? Why start your relationship with them on a falsehood? All they have to say is, I want to cut back. I want to decrease my use. And I've started people who told me up front, I still want to use heroin on the weekend. Is that okay? I said, well, it's not, I'm not the one to give you permission, but take this medicine, see how you feel on it. For one thing, if they take their buprenorphine on Friday.
Dr. Trigg?
Yeah, go ahead.
We're at 20 minutes.
How many minutes?
20.
So I have 20 left, right?
Yes.
Yeah, thank you. Thank you very much.
Yeah.
So this is extremely important. If the patient takes the medicine every day on Friday and they skip Saturday, right, because they want to get high, you know what the reality is? Half of the medicine is still in their bloodstream on Saturday. So if they use heroin, they're not going to get high, or they're not going to get nearly as high, and they may actually not have any cravings or have very little craving. So I don't, I just say, try the medicine, see how you feel. You're not going to know until you try it. But, I don't, I'm not trying to trick them, but the fact is I don't exclude people who tell me they want to keep using heroin. If they use buprenorphine, guaranteed they will be using much less heroin than they used before the treatment. The term is harm reduction. It is decreasing their harm. Think of the kids in that family to have a mother or father who's using heroin 5 times a day, 7 days a week. compared with a kid whose mom or dad is just using it on the weekend. Do you think that's going to change that kid's life? I think so. I think it's going to make a dramatic change. It's not the ideal. It's not what I would wish for someone I loved, but I don't get to make those decisions for other people, right? They're not my children. So, but it is decreasing harm dramatically just to start people. And eventually, studies are very clear. The longer people are in treatment, the less heroin they use, the less other drugs they use, and the more likely they are to eventually stop using. It's crystal clear. So you want to keep people in treatment, engage them, be on their side. I'm not here to catch you. I'm not your enemy. I'm here to help you. This medicine is going to help you out no matter what. It really will help you out no matter what, as long as you take it. We highly recommend that people receive other psychosocial support. We want to address health problems. We want to address their medical problems. At least half of people who inject drugs have hepatitis C, which is 99% curable today with 12 weeks of treatment. And otherwise, they have a high risk of dying. But until their addiction is stable, it's going to be very hard for people to make an appointment, go through the testing, and get this treatment. So the goal is to stabilize people so they can get their hepatitis C test treated, so they can get their depression or anxiety or PTSD or bipolar disorder treated, and to get the psychological support that they need to have a good life. However, engaging in therapy should not be an absolute requirement to continue people on buprenorphine. So I worked in a program in Albuquerque where people were not given an appointment to follow up with me if they didn't go to the weekly group therapy session. I have nothing against group therapy sessions. I said to my patients, go to it. They're really good people. You're going to get a lot out of it. And some of the patients loved it, but others couldn't do it. They just couldn't do it. It just was too painful. They had too many bad experiences in the past. They just were not ready to engage in therapy. So the answer to that is keep them on buprenorphine, because my experience was 6 months later, a year later, they go, Dr. Trigg, I want to get back with my partner, or I want to get my kids back, and I need some help. What do you recommend? And that's when I pick up the phone and put them on the phone with a psychotherapist, a social worker, a psychologist, with someone who can help them out. But to not continue treatment for someone who is not engaged in therapy is a huge mistake and should not be done. Okay, now here's the $64,000 question. How long does a patient have to be on treatment? So in 1997, they said a drug-free state represents an optimum treatment goal. Everyone wants to be off all medicine. Everyone wants that. But research has demonstrated that this goal cannot be achieved or sustained by the majority of opioid-dependent people. So if someone says, I don't want to be on this forever, doc, what do I say to them? I said, I understand. Start the medicine. I recommend you be on it at least a year. But the day you want to stop, I swear to you, I will start a taper the day you ask me to do that. You are not a slave to this medicine, but you will see that you will have a much better life if you stay on it. Because the reality is that 80% of people on methadone or Suboxone relapse within 12 months if they stop the treatment. Now that's a heavy and important piece of information. But that's the fact. I don't lie to people. I say you have to understand that you have an 80% chance of relapse. And I don't have a crystal ball. Maybe you'll be the 20% that doesn't relapse, but the risk is really extremely high. 80%, 8 out of 10 people will relapse. So the answer is to stay on treatment. And I said this last time, just like the answer to high blood pressure is you stay in treatment. We don't encourage people to get off their lisinopril, do we? We don't say, oh, you've been on your high blood pressure medicines long enough, 2 years. Let's get you off that medicine. You've been on your diet, you've been on your insulin for 5 years. That's enough. Why do you want to be a slave to insulin? Stop your insulin. We don't do that for other medical situations. We don't do it. So we encourage people to stay in treatment because relapse often comes with death. So my favorite actor of all times, Seymour Philip Hoffman, winner of Academy Awards, multimillionaire, had not used any heroin for 20 years, they said in the obituaries, but 20 years later, in New York City, a few blocks from where I'm sitting now, he locked himself in a room and injected heroin, and it had fentanyl in it, and he was dead. So should he have been on methadone or Suboxone for those 20 years? Think about it. He wouldn't have needed, in retrospect, we know he didn't need it for those 20 years, but he'd still be alive. If he had stayed on buprenorphine or methadone, it's much less likely that he would have relapsed. It's very, very less likely. So is it worth being 20 years on a medicine to not die after 20 years? They told me when I was on cholesterol medicine that they were lowering my risk of stroke or heart attack by 5% for the rest of my life. That's the reason I was told to be on statins. I assure you, the death risk for someone addicted to opioids is much more than 5% for the rest of their life. It's probably 5% a year. So what can I tell you, folks? That's the way it is. Can people abuse buprenorphine?
Dr. Trigg,
Go ahead.
we're at 10 minutes.
How many minutes now?
10.
10 minutes, okay. Can people abuse buprenorphine? Well, how do you define abuse? I think you would be a monster to be taking your Suboxone every morning and someone you love, your child, your spouse, your best friend is going into withdrawal in front of you and is going to go out on the street and buy heroin, right? And maybe commit a crime or, have to trade sex for money. And all you need to do is give them a little tiny piece of that strip to put under their tongue. You'd be a monster not to share it with them. So do people share the buprenorphine? They do. They do. And some people will sell it because they need money for whatever. It may be for heroin or it may be to buy the kids, books or shoes. So yes, that's the reality. However, people who buy it on the street use it to take away their withdrawal and their cravings. So they think about it. They are using it on the street for the exact same reason I'm prescribing it. I don't endorse it. It's illegal. I would lose my license if I encourage someone to, in fact, if I didn't take all precautions to discourage my patients from sharing buprenorphine. But does it get shared? Yes, it gets shared frequently. And everyone who buys it on the street is not using heroin for 1, 2, or 3 days. It is actually making them safer. And there's a published study, that the more buprenorphine people buy in the street, the less likely they are to die of an overdose. So from a public health point of view, this is not the problem with buprenorphine. But if you bring it up to a lot of law enforcement, they'll go, oh, it's sold on the street, it's a bad thing. No, it's sold on the street, and we need to make more of it available legally through prescriptions. Now, I'm not going to spend much time on naltrexone. It's an antagonist, and it's a pill or a monthly injection. The pill is ineffective for treatment of opioid use disorder because people don't take it every day. So to get around that, a company came up with an injectable that lasts for a month. So once you get the injection, you can't feel heroin. It doesn't make you sick like disulfiram. What is that called? Antabuse. Antabuse for alcoholism. It doesn't make you sick. You just don't feel anything. You don't feel the heroin. So it sounds like, well, that's good. It's not an opioid. You don't become dependent on it. It has no possibility of being sold on the street, right? You can't abuse it. Gee, everyone should be on this. The problem is most patients only get 1 or 2 injections because it doesn't make them feel at all good. In fact, some people become anhedonic. They can't even enjoy other things in life, other pleasures. So because of that, when patients are given the option of methadone, Suboxone, or naltrexone, very, very few of them choose naltrexone. If a patient wants to be on a non-opioid treatment and they are highly motivated, absolutely, go for it. The problem is it costs $1,000 a month. Fortunately, it is covered by Medicaid now in most states, but it costs $1,000 a month. The other problem is because it's a non-opioid, when you stop it, you have no tolerance anymore, and it increases your risk of death. So naltrexone has been around for a while, the injectable form. The other thing, by the way, is you have to be abstinent for 7 days before you start naltrexone. So if my patients could be abstinent for 7 days, they wouldn't be my patients. Very few of them, none of them. I mean, you're telling them to stop being addicted for 7 days. It's not possible. So it really only works in inpatient settings. It's been heavily advocated for jails and prisons and drug courts where people are supposed, theoretically abstinent because they're behind bars, even though that isn't always true. But even in inpatient settings, it's very hard to start people on naltrexone. So the reality is that it has not been shown to decrease the death caused by opioid use disorder. So that's why most experts consider it a second-line medication that has unfortunately been unethically promoted by the pharmaceutical company that makes it, especially to jails and prisons. So it is very widely used, much more than methadone and Suboxone in jails and prisons. And here's the New York City subway, giant ads, all over the subway system, because it's a very profitable medication. But it really has a secondary role. This is what methadone costs for a year. This is what buprenorphine costs for a year. And this is what naltrexone costs for a year. It's very expensive. And I don't think it's for most patients, it's not worth the money. I am going to play a 4-minute tape that was on NPR last week. If I can be reminded how to do it. Let's see. It was a right click. No. Oh, I know what I need to do. There we go. Okay, well, since I'm running out of time, I think I'm going to have to skip it. You remember that woman who was in 8 detox programs. I just want to make it very clear that detox is not the treatment for opioid use disorder. And yet, easily 3/4 or 2/3 of rehab programs all over the United States are not using any medication. They are treating it with detox, meaning cold turkey or supported with medicines. But after that, people just get talk therapy. And we've known for 100 years that that is not adequate treatment for opioid use disorder. And of the few that do use medications, most of them are using only Vivitrol, the second-line medicine. So we have a problem, a huge problem. It's a multi-billion-dollar industry. And it reaches points of absurdity because while I was still in New Mexico in 2009, the New Mexico state government was funding a rehab program from the Church of Scientology, which religiously doesn't believe in medicine. So they were giving people saunas and they went horseback riding and they had a vegan diet and it was wonderful. It was going to a great spa. Everyone loves it. Who wouldn't want to go to a nice spa? But it didn't treat their opioid use disorder. And everyone who left it, if they kept track, of course they didn't because it would make them look bad, I can guarantee you that everyone, 90% of people relapsed. And this was a scandal because, I mean, they obviously had a certain kind of friendship, let's say, with certain politicians in the state legislature who voted to give them millions of our tax dollars, $1 million in state and county funds for a program that did absolutely nothing to treat addiction. So this is a huge problem, and it continues, and that's why I wanted to play that NPR. So these slides will be available, so please look up that link. It's really a scandal. It was a scandal. Everyone who goes to an emergency room with a overdose, everyone with a opiate-related problem should be started on buprenorphine on the spot. This is the gold standard. This is what we're starting to advocate. That's been advocated for a few years now. It's still not happening in New Mexico. It's not happening in New York, except in certain places. But if someone walks in the door and they have an opioid use disorder because they're in withdrawal, or they've had a relapse, or they have an abscess, they should be started on the spot on treatment. There is absolutely no reason not to do it. It would be like someone comes in with a heart attack and you go, well, you really have done this to yourself by, eating too much and, having a bad diet. And this is your fault. And here's a list of places you can call tomorrow and see if you can get treatment for your heart attack. We wouldn't do that. We would never do that. That's what we do every day in emergency rooms all over the United States for people who show up with an overdose. Now, we happen to live in the incarceration capital of the world. This is the US incarceration rate compared with other Western wealthy nations. And New Mexico's is even higher than the United States. This is the incarceration rate. So how do we deal with drug problems in the United States and in New Mexico? We put people in jail. That's what we do. And we've been doing it for a long time. State prisons, local jails, federal. But it wasn't always so. Until 1970, the US had the same rate of incarceration as all those other countries I showed you. So something happened in 1970, and it was called the War on Drugs from Richard Nixon. And this is his attorney who went to prison, John Ehrlichman. He said, we knew we couldn't make it illegal to be either against the war, that was the Vietnam War, or black. But by getting the public to associate the hippies, meaning the anti-war people, with marijuana, and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. Well, that's exactly what they managed to do. Since 1972, they have disrupted Black communities, communities of color, by the war on drugs. Because who is it that's getting locked up?
Dr. Trigg, we are at time.
So this time. Okay,
Yes.
it's okay. I'm going to take 5 more minutes and then we'll
Okay, 5 more. Great.
So please let me know. So here's the New Mexico incarceration rates by race. Okay, if you're Hispanic, or you're Black, or you're Native American, you have a much higher rate of being incarcerated in New Mexico. So again, the racial issue, starting with the Nixon administration, they planned it that way. So this is New Mexico. This is a great set of slides about incarceration in New Mexico and who gets incarcerated. So if you want to treat people, this is the death rate when people come out of prisons and jails. And we've had this data for New Mexico as well. Within a week of getting out of a jail, within 1 week, the rate of death from overdose is immensely high. The only way to stop that is to start people on treatment while they are incarcerated. It's rarely done to this day. It's increasing dramatically. In Rhode Island, they started within 6 months, they decreased the death rate by 61%. New Mexico has been treating opioid addiction only at the Metropolitan Detention Center since 2006. No other county jail does it, and the prison systems don't do it. So we have a lot of work to do in our very own New Mexico. So I'm just going to end up by saying that New Mexico has one of the most robust syringe exchange programs in the United States. 9.8 million syringes in 2018. That's actually as many as exchanged in New York City, which has 4 times the population of all of New Mexico. So we have much to be proud of in New Mexico. And this program has been written up. There are movies about it. It's really an important program. We give out naloxone. We've been doing that since 2002, which saves many lives. But we have a lot we can do better. If you are in New Mexico, or this is a photograph from Philadelphia, this is where you inject drugs, under a highway, in the street, in an alleyway. And if you happen to live in Canada, this is where you inject drugs. Where would you rather have someone you love who is addicted to opioids ingesting drugs? In the street or in this facility? That's called a supervised injecting facility. And New Mexico's legislature, I haven't followed in the last week, but 2 weeks ago, the main committee unanimously voted to have a supervised injecting facility start in New Mexico. So we may become, New Mexico, may become the first place in the United States to legally have a supervised injecting facility. Canada has 50 of them, and they're going to have more. But they also have what's called heroin-assisted maintenance for people who aren't successful on methadone and buprenorphine. And this is a clinic I visited in Vancouver, where you line up every day. They don't give you heroin to take home. It's prescribed. A nurse hands it to you in a syringe. You sit there and you're supervised and you watch so you don't overdose. So there's incredible amounts that we can do to make people's lives better and to save lives. And I hope that some of you will get involved in these efforts in New Mexico to treat people, to work with harm reduction, to get involved with the supervised injecting sites that are likely to pop up soon. We have so much that we can do. We also have a profit-oriented healthcare system that has failed people who use drugs for many reasons, just like it's really failed all of us with COVID and pre-COVID. And I think we should be advocating for a single-payer Medicare for all national health program. And Martin Luther King said it better than anyone: of all forms of inequality, injustice in healthcare is the most shocking and inhumane. So on that note, I will finish. This is a methadone clinic in Indonesia, and this is one I worked at in Burma. This is a worldwide pandemic, and the solutions, just like the vaccine is for COVID, the solutions are really buprenorphine and methadone, and treating people like human beings deserve to be treated as people with human rights. And we need to treat people the way we would want our children to be treated. Thank you.
Thank you so much. I'll use the little emoji clapping of your hands. Thank you so much. Excellent. Well, we do have some time for some Q&A. There were a few questions in the chat, and I'll try to. I'm so sorry.
Will I be able to? Yeah, I'll save the chat too.
Yes, you should have access to the chat, and you can kind of scroll through and pick as you want, or you can open up the floor however you see fit.
Yeah. So have you looked at the chat, or do you want to read questions? I start doing.
Yes, I can read the questions. Okay. So there's a lot of thank yous and how important this is. And again, this has been recorded and it will be made available. And if I can get a couple of questions were if there'll be access to the slides that you presented both today and tomorrow, last week, sorry, if you don't mind sharing those with me or Lori, and I can make sure that they go a part of this whole presentation.
The people in this field share each other's slides all the time. Everything's in the public domain, and please make use of it and share it with people.
Awesome. So the first question pertaining to your presentation, can I'm gonna botch some of these names. I'm sorry. Exon be described as to patients who are misusing multiple substances,
Who are misusing what?
i.e. meth, multiple substances such as meth or cocaine plus opioids?
Yeah, I'm really, thank you for that question. I should have planted you to ask that question. So to this day, a lot of clinicians in the field, they do urine testing. And if someone is positive for another illicit substance, it could be cannabis in some places, that tends to be less likely these days because it's legal in so many 14 states now. But in many places, if you're positive for another illicit substance, well, it's worth talking to people about, tell me about it. But it shouldn't be a reason to discontinue treatment. And I'll tell you why. We are only treating opioid use disorder with Suboxone and Methadone. So if you're using or misusing or addicted to methamphetamine, I'm not treating that. I'm not treating your methamphetamine addiction. So why would I discontinue your treatment with buprenorphine? If you're on buprenorphine, you are using no heroin or certainly much less than you were before. So by definition, if you take the medicine, you're successful. So why would I end that success on buprenorphine because you're using another drug? It makes no sense. It's like having a patient being treated for diabetes, right? And then they come and they go, well, I have cancer. And you go, well, you can't be my patient. I'm not going to treat your diabetes anymore because now you have cancer. It's the same thing. It's another disease. It's another brain disorder. Methamphetamine misuse, or addiction is a very serious problem, but it doesn't mean you can't still be on buprenorphine. And the reality, by the way, is over time, people on buprenorphine decrease their use of other illicit substances. Sometimes they were using other illicit substances to control their withdrawal symptoms. That was actually very common. Why are you using meth? Now, it doesn't make sense to us in some ways. Buprenorphine or heroin is a downer, right? And methamphetamine is a stimulant. So you go, well, why are you using both a stimulant and an upper? But that's not the way people see it. They feel some way that they feel they need to use a substance to alter their brain. And if they're using methamphetamine, then, now obviously you want to talk to them about the methamphetamine use, but it's not a reason to discontinue the buprenorphine use if they're coming to the clinic, right? And they're taking their buprenorphine. They're not doing anything that should be, there's no reason for them to be punished or even worse, discontinued from meth. Okay? Is that?
The next question in the list is, what about I'm saying that wrong. Subdexic, is that correct? I could be messing that up. This is not my field.
Yeah. What, spell it?
It's Subutx. EX.
Subutex.
Subutex, thank you.
Okay. So Subutex was the brand name for pure buprenorphine. And I don't think it's on the market anymore. But I said, all the buprenorphine is combined with naloxone, right? Except for it, and that the brand name originally was Suboxone, right? But now there's lots of different generic forms, right? But the brand name for the pure buprenorphine was Subutex. So Subutex is pure buprenorphine that, as I said, really should only be prescribed for pregnant women. One reason it shouldn't be prescribed otherwise is that it has a higher street value. So it will actually sort of encourage people. Let me put it this way, it's more likely to be sold on the street, to be diverted and sold for money on the street, because the street value is probably twice what it is for buprenorphine. Because if people want to inject buprenorphine, they know that the pure Subutex will not put them into minor withdrawal. What I haven't pointed out is that if people really want to inject they'll inject, and they can actually overcome the withdrawal from Suboxone as well. So it's not 100% effective in stopping injecting. But on the other hand, it's very unusual to have patients who were injecting it over long periods of time.
Is it true that Suboxone has taken over the drug trade in gels?
Yes, to some degree, because it's so easy to smuggle that film. You can put it in your ear, your ear canal, right? I mean, it's because a tiny, tiny piece will take away your withdrawal. On the other hand, if you're really bored in jail and you really want to get high, you might inject that Suboxone, but you'll also be more likely to be seeking heroin. But Suboxone is very common in jails. So what do I say to the jail administrators and jail jail leadership who say that? I say, well, the answer to that is to put everyone on Suboxone who needs it. There'll be no black market if everyone who needs it is given it in the infirmary. That's the way to stop the black market. And the reality is the black market doesn't just involve incarcerated people, it involves the correctional officers. I mean, there's a lot of money to be made and a lot of favors to be gained from very desperate people who are in terror of withdrawal from opiates. People will do anything. I mean, people sell themselves on the street to a stranger for $10. So people will do anything to get money because their brain is miswired this way. So it's cruel to not treat people in a jail the same way they'd be treated in the community. It's called a community standard of care. The jail legally is required to provide the community standard of care, which is methadone and Suboxone. And yet only the Metropolitan Detention Center in all of New Mexico, to my knowledge, at this point, provides methadone or buprenorphine, except for pregnant women, by the way. I used to say, oh, methadone is such a horrible, dangerous drug, we'll only give it to pregnant women. But that's in fact what they've been doing for decades,
The last question I'll read before I'll open the floor is how can social workers help advocate for treatment on the spot in medical settings?
Yeah, well, I've worked with social workers in methadone programs, they're in buprenorphine programs, they're in rehab centers, and a rehab center that treats people with opioid use disorder and does not inform them of medication for addiction treatment and doesn't refer them or offer it to them is committing malpractice. So I would really recommend not working in an unethical place like that. And I've known personally a number of social workers who couldn't continue in rehab programs that were charging $40,000, $50,000, $60,000 a month and guaranteeing that people were going to relapse when they got out. I mean, how can I tell you? It's unethical. It's an unethical setting. On the other hand, you certainly have a voice and should be saying, I thought that the treatment is, that we should be giving people information about medication-assisted treatment. This 12-step, and this is a bit of an aside, the father of methadone, Vincent Dole, was the non-quote, they used to use the word alcoholic, the non-alcohol use disorder person on the board of Alcoholics Anonymous and was a personal friend of Bill W. If you know about 12-step programs, what do you think Bill W. told Vincent Dole? I wish we had a medicine like methadone for alcohol use disorder. How many people in AA do you think know that? This is well documented. He wished they had a silver bullet like methadone for alcohol use disorder. So all this anti-medication stuff is just people just made it up. It's just stigma. It's based on lack of information and on prejudice. Think about it. Even the 12-step programs. So I always tell patients, 12-step programs are social support. They are very powerful. But if you have to lie and tell people that you're not on methadone or buprenorphine, you should find another group to work with, because you don't want to start a relationship by lying. But many of them will not accept people on medication, or they'll give them a lot of negative feedback. So again, a lot of social workers involved in 12-step programs, they should not interfere with people's treatment, evidence-based treatment, just like they shouldn't tell people to get off antidepressants or psych meds, which some of them do. There's actually a program called Smart Recovery, which is similar but a little different than AA, and is more open. In fact, it is totally accepting of people on medication for opioid use and for other substance use disorders.
Awesome. We have 7 minutes left, so I want to open the floor for anyone in our audience to ask questions, and that way I don't botch up all of these really great names and things.
Oh yeah.
So
thanks for trying. And is my email on my last slide? Oh, I'll put it in the chat right now. Okay. So if anyone has either a personal question or a question comes to you in the middle of the night, I won't answer it in the middle of the night, but you're very welcome to contact me. Okay.
Excellent. Thank you. So with our last couple of minutes remaining, I will hand the floor over to our participants. You can unmute yourself, or you can use the raise hand feature if you have a question for Dr. Trigg before the end of our day or evening. Yes, Earl.
Earl, so is there any legislation pending in New Mexico that you're aware of that addresses some of these issues?
Good question. Well, there is the incredible news about the. There's actually two pieces of legislation I'm aware of. One is to for the state to plan and implement a drug consumption room or supervised injecting facility, and that passed unanimously. A major committee that Debbie Armstrong, it was a bill that Debbie Armstrong introduced, who's been a very much of a leader on this. And the other thing is they're trying to set up a pilot program to be able to prescribe an agonist, injectable agonist, not heroin, but it would be dilaudid hydromorphone for people who are, again, struggling, who have not been able to stop using heroin even after being on methadone or buprenorphine. So New Mexico is really on the cutting edge on those two bills. I don't know if there's a bill to mandate use of MAT in jails and prisons. There really should be. New York State had a bill like that was so close to passage that the prison system, after 35 years, finally started continuing people on methadone. There are now 7 New York State prisons just in the last year that have started to continue people because they were afraid that the bill would pass that would mandate it. So that seems to be the way to get things done. There's no reasons for jails and prisons in New Mexico not to be following the standard of care. By the way, every major public health and correctional health organization in the United States advocates medications for addiction treatment in jails and prisons.
Thank you.
Yes, you're so welcome. I'm sure you all can sense the edge of frustration in my voice from doing this for many, many years. There is progress happening. I have to say, it is really gratifying. My frustration is that it hasn't happened sooner, but that's the way things are, I think, in the United States. Change is possible. It does happen, but it's just excruciatingly slow, you know? We are going to get a $15 minimum wage, but it's going to take a while, you know? Does New Mexico have a $15 minimum wage? I'm trying to remember. I think Bernalillo may. But yeah. Yes, so we have to keep plugging away. These are human beings. It affects everyone's life in New Mexico. There is no one I've ever met in New Mexico that doesn't have a friend, a coworker, a family member who's been impacted by this horrible epidemic. And people are entitled to get the best treatment, not secondary, not adequate. They're entitled to the best treatment there is. And you know, there's a lot of work to do, and it involves all the health professions, all the people on this call can and hopefully will play a role in this.
Absolutely. Absolutely. Well,
Yeah.
we are at the end of our time together this evening. I thank you, Dr. Triggs, for your time and your expertise. There are many folks in our chat just really appreciative of your time. So on their behalf and mine, thank you so much. Lori, is there anything you would like to say before we wrap up this evening?
No, I just want to thank everyone for attending and Dr. Trigg for providing a very informative presentation on a very important issue, and also to thank Dean Duran for her support and collaboration on this series.
Okay, well, thank you. Thanks again. You all get your COVID immunizations, and when I'm in New Mexico next in the summer, maybe we can do a face-to-face class or two.
Yes,
like
definitely.
like in the
Yeah.
old.
If we know how to do it, if we remember how to do it.
Yeah. All right. Best of luck to all of you. And thanks again for.
Thank you.
Thank you so much.
so much.
Thank you. You've inspired me to take the substance use class this summer, the elective. Sorry, there's no face attached. I'm eating dinner.
I'm so pleased to hear that. Thank you very much. Thank you. That
Yeah.
really makes it all worthwhile.
Same for me as well, Danielle. So
Good,
thank
good.
you, Dr. Trigg.
Incredibly important work to do in New Mexico. And you know, we do have this amazing harm reduction program all over New Mexico. It's like I said, it's one of the best in the country. So I mean, I'm sure they hire social workers and counselors and nurses. Go for it, guys.
I'm sure. Thank you, everyone. Have a very good evening, and we'll see you.
Good night.
Be well.
The minimum wage is $10.50 first.
No, really?
In New Mexico, yeah. Why would that surprise you?